Hello, I'm Norbert Gleicher, MD. I'm the Medical Director and Chief Scientist here at the Center for Human Reproduction in New York City, with my colleague and friend David Barad, who heads up our clinical IVF program and our research program. And today we do things a little different because our own Carson, representing you out there in the public and the many questions you have been sending our way, she will ask those questions and we will try to answer them.
Okay. Question 1 is, if doing a day 3 FET and had no choice, parentheses, I'm assuming their physician said they had no choice, what type of transfer do you suggest, medicated or modified FET?
So it's determined that the patient has to do an FET, a frozen thawed embryo transfer. Basically, and David, interrupt if you have anything to add or of different opinion, but basically the literature suggests that natural cycle or so-called artificial cycle building are very similar, even though the more recent literature trends towards use of natural cycle. So we here at the CHR, if the patient still has regular periods, we will start with a natural cycle, but we are monitoring that cycle very carefully. And if it's not the normally progressing cycle towards development of a follicle that either will ovulate on its own or can be ovulated, then we help out, and then we call it a modified natural cycle.
So you have to kind of dissect the question a little bit, because what do they mean by medicated? So traditionally, when we started doing these cycles, everybody would suppress natural ovulation with like a long GnRH agonist like Lupron.
Yeah.
And then when the cycles completely shut off, you would start some estrogen to build up the lining, and then when the lining had grown appropriately, you start your progesterones and stuff like that.
Definitely an artificial cycle.
That's an artificial cycle.
Yeah.
What we're doing is we've moved away from using any suppression at all. So we would, if somebody's cycling naturally, we'd start at their time of their period, and we'd observe. And if the endometrium is growing beautifully, maybe you don't need any estrogen.
Right.
But we need that endometrium to get up to optimally 8 to 10, but we can live with 6, 7, if that's as far as we can get. But we need to get there. And so if you need extra estrogen, we'll supplement you with some estrogen. So that's what Dr. Gleicher means by a modified cycle.
Yeah.
And then ultimately, progesterone. We generally will add progesterone.
We always add progesterone. And the older the patient is, the more she obviously needs progesterone support.
And then on top of that, depending on what we know about your immune system, you may take some baby aspirin, you may take some prednisone.
Yeah. Those are separate things from the basic question. But maybe one additional explanation why we have gone away from long Lupron downregulation ahead of time. One of the reasons is our patient population, which is a very old patient population, and we are obviously concerned of suppressing the ovaries. And so we are not using long Lupron at all, almost, unless we have maybe a young egg donor or somebody as young as an egg donor. So by explaining how we do it, we don't want to give the impression that everybody should do what we are doing. What we explained here, how we do it, is geared at specifically our patient population.
Okay, fab. Question 2. What are some chromosomal abnormality concerns with age 40 and above?
We're all concerned about chromosomal issues. It's part of nature. It's part of the natural process of reproduction. As you get older, aneuploidies, meaning a miscount in the number of chromosomes, become more common. And that can lead to potential miscarriage. It could lead to a child who could be, have a viable aneuploid problem like Edwards or Down syndrome. And so we all work to avoid that. Now these days, as far as ongoing pregnancy is concerned, it's very easy to do prenatal testing early on to determine whether a pregnancy is healthy or not. I will say that among our patients, I can't really remember a case in which we had to recommend somebody to terminate a pregnancy.
No, I cannot remember either. Yeah.
We have patients who do have miscarriages, and as I said, that's a natural part of life. Some people have miscarriages, and those miscarriages, these days we know about half the time are related to
if you consider chemical pregnancies as part of the miscarriage spectrum.
But even when we look at the tissues that we get from our patients who have miscarried, about half the time they're not aneuploid.
No, that's correct. Yeah. Sometimes they will give us a normal chromosomal complement, and then we better start looking for the real reason why she miscarried. But I think the question we got is which chromosomal abnormalities are more concerning? And this is a question that we now can answer because it was the Center for Human Reproduction, which now 10 years ago, in 2015, to the surprise of really all of our colleagues, and I know that because I was the one who gave the talk at the annual ASRM meeting, for the first time reported 4 healthy pregnancies after we transferred embryos which supposedly had been chromosomal abnormal. And believe me, you should have been in that room when I made that presentation. It was deadly quiet. It was such a shock for the attendees. And the room was full because from the title they knew what was coming. And now since those days, it's 10 years, we have learned a lot about transferring so-called abnormal chromosomal embryos. And more clinics, still a minority, but more and more IVF clinics have started to transfer at least selectively.
So one of the problems is that in the early days of doing genetic testing, they didn't have a technology which could identify full aneuploid from mosaic aneuploid, and everything was classified as aneuploid or euploid.
They still don't have it. They think they have it, but they still don't have it.
Well, they have. Yes, they've gotten a little better.
Yes, they have gotten much better.
And so, a lot of our colleagues, then and even now, refuse to transfer embryos that are not 100% euploid. Whereas those that are mosaic, meaning some cells in a biopsy are normal and some cells in a biopsy are abnormal, those embryos have an ongoing pregnancy rate of around 40%,
right,
give or take.
Basically a normal pregnancy rate.
And while it's a little bit less than the inflated pregnancy rate you can get with a fully euploid biopsy, it's still very respectable. And we would have been thrilled to have that rate when we started doing IVF 20 years or 30 years ago.
Of course.
So the mosaic, those embryos that have a single mosaicism have really very good pregnancy rates. Those embryos that have segmental changes, meaning just a little part of the embryo is of the chromosome is duplicated or
missing.
deleted.
Yeah.
They have very good pregnancy rates as well.
They have actually the best pregnancy rates to some degree.
And for those embryos that have a fully aneuploid diagnosis, the chance of ongoing pregnancy is smaller.
But there's still pregnancies.
But we still get some.
We have some pregnancies, unquestionably.
We had one pregnancy who the diagnosis was that the embryo had Turner syndrome, meaning you had XO, just a single X chromosome in the biopsy. And Turner syndrome is a syndrome where you have a female body type, but you never become reproductively capable.
Or you're very limited in your reproductive
those are the
capacity.
mosaics.
Yeah.
This one was a full Turner syndrome diagnosis. It turned out that the biopsy was wrong, that the patient ended up having a normal female, and there was not even any evidence of mosaicism in the baby.
Yeah.
So the bottom line is even these fully aneuploid biopsies can sometimes be wrong, although not as
frequently. Yeah, and there's even there's some even maybe even more interesting anecdotes, because we have 3 or 4 cases by now where we transferred selected embryos that were reported as abnormal. The patient miscarried, and we were convinced that they miscarried because of the abnormal embryo they got. And then when we tested the pregnancy, we found out that the pregnancy was actually chromosomally completely normal.
Yeah.
So this chromosomal testing is not very reliable. We therefore do not recommend it routinely. Here at the Center for Human Reproduction, we offer it if patients want it, but we do not recommend it.
The point is that it may be a way of selecting a best embryo when you have a range of embryos to select from.
When you have a lot of embryos.
But when you only have a few, there's no point in doing selection. And it's not a reliable way of deselecting your embryo.
Yeah, it is, as Dr. Barad earlier said, what it may be doing is it will give you the better embryo earlier that will get you pregnant, and so you might get pregnant a month or 2 or 3 quicker, but at significant additional cost and at significant loss, because as we started out saying, most of our colleagues to this day will not touch an embryo that is reported in any way as abnormal. And that means that many of the good embryos are not being transferred, and that means that the cumulative pregnancy chance of your embryo cohort in an IVF cycle is reduced. And with that, your cumulative pregnancy chance.
Also, in a fresh transfer, you get the transfer today.
Yeah.
If you're doing PGTA, it takes 2 weeks to get the result back.
You have to freeze the embryos.
It takes a month or so
Absolutely.
before you get to your transfer, so you may not get pregnant sooner.
Yeah. Even if you do, it's minimum.
Yeah.
Yeah.
Okay, so thanks. We've really enjoyed this question and answer time. We look forward to doing more of it in the future. And if you have other questions, please feel free to send them to us. And if they're often asked, we'll bring it back to one of these sessions so you can hear our answer.
Thank you very much for listening.